we're here today with Ruth Cunningham, who is from the Department of Public Health at Otago University in Wellington, and she's been speaking at the Royal New Zealand College of General Practitioners Conference in Auckland. So welcome, Ruth, it's nice to meet you. So what have you been talking about with the candidates today?
So I've been talking about some work that I did as part of my PhD, which was looking at cancer among people using mental health services in New Zealand.
Okay.
Both how common cancer is, but also cancer survival, what happens after someone is diagnosed with cancer, how likely they are to die of it, and looking at comparing people using mental health services to people without a history of mental health problems.
Wow. And what conclusions and results did you get?
So when we looked at how common cancer was, we found that cancer is just as common amongst people using mental health services, but that when we looked at cancer mortality or dying from cancer, people were twice as likely to die from cancer under the age of 65 compared to people without a history of mental health service use. And then we looked at cancer survival in breast and colorectal cancers. We compared people who'd had contact with mental health services in the 5 years before their cancer diagnosis with those who hadn't, and we found that for people who had been diagnosed with schizophrenia and bipolar disorder, they were nearly 3 times as likely to die from breast or colorectal cancers after being diagnosed within 5 years of diagnosis compared to those who didn't have a history of mental health service use, so much more likely to die. And also for everyone else using mental health services, so without those psychosis diagnoses, they were also at significantly increased risk of dying from their cancers.
Wow. And did you look into what the reasons might be behind that?
So the most important thing is, so yes, there's a discrepancy, but why? And so we looked at whether it was about cancers being diagnosed late, and we found that for the group of people who had a diagnosis of a psychosis, their cancers were diagnosed late. That was a part of the explanation for doing worse. But for other people using mental health services, there wasn't any evidence of cancers being diagnosed late. So it wasn't about that, but they were still doing worse. We also looked at whether having other comorbid illnesses at the same time was a factor. We know being more likely to have diabetes, being more likely to have hypertension, being more likely to have other health things going on as well as cancer and mental illness. And we did find that burden of comorbid illness was an important explanation for both groups, for both those with psychosis illnesses and for everyone else using mental health services as well. That was a factor, one of the explanatory factors in doing worse from their cancers. And we know from the work that my colleague Diana Safati has been doing around comorbidity and cancer, that actually we need to start thinking about those comorbid conditions as actually not necessarily a contraindication to cancer treatment, and not necessarily a reason for survival inequalities that we can't do anything about. Actually, we need to think about them as an amenable cause of differences. So actually, that finding that comorbidity matters here, it makes us think about how important good primary care is, and how important actually thinking about managing all the different things that are going on in an individual life.
It's amazing because talking to you now, I just sort of instantly think of my severely mental ill patient who had breast cancer and how we managed to get her through. And so you sort of think actually I was more worried about her mental illness at the time than I was about her cancer, and so it makes me really rethink what I'm doing with my patients.
But also I think so we're doing a follow-up study where we're interviewing women who've had breast cancer and previous mental illness about their cancer treatment, and finding that people say to us that their experience of cancer service is actually really good because this is a service that they are going to voluntarily, that they feel much more positively about cancer services and about the way they're treated. That when they're in hospital, people will bring them flowers, and it's a condition that that is not so stigmatised as being in hospital for a psychiatric illness. So I think it's a really interesting and complicated.
Very complicated. I can imagine teasing it out. It's like undoing a fishing line. Oh, very good. So you've got some more research planned, have you?
So one of the things that we weren't able to look at I used routine data on use of mental health services and matched it to the cancer registry and to mortality data and to hospital service data. But what we weren't able to do was look very well at cancer treatment, whether there were differences in delays to cancer treatment or receipt of cancer treatment, because there's so much private cancer care in New Zealand, and as you can imagine, those who are using mental health services are not those who are accessing the private care. Then actually, when you look at comparing receipt of cancer care, receipt of breast cancer surgery, say, between people who are using mental health services and others, it looks like you're much more likely to get surgery for your breast cancer if you have a mental illness, because we're missing all of those, all that private care. So we can't make a useful comparison. So we have to do other kinds of research, actually go out there to the patient notes and things to find out what's actually happening in treatment, because when we did our work, we found that there was still a discrepancy in survival, even after adjusting for everything we could adjust for, and that may well be about differences in treatment receipt. And I mean, as clinicians, we know that it's hard enough navigating through the cancer system, through cancer care, without having all these other problems and without having, with good social supports and everything. So it is likely that people aren't making it all the way through, or they're not necessarily making it all the way through in a timely manner. So I think it is really important to try and investigate that, and it's important for being able to communicate my work to cancer clinicians to know what's actually happening in there, what's happening in at that bit of the system. So I'm interested in doing some work on that. We're also doing, as I said, some qualitative work where we're actually talking to people who have had this experience of both mental illness and cancer about what that's been like and how that could be better. Because I think reading the literature, there's a real absence of the voice of people with experiencing mental illness, the voice of patients in this area. So actually trying to bring that sort of reality back into the area. So doing more work.
Very good. Well done, and thanks for coming to the conference. It's been great having you, and it's really lovely having you talk about stuff that's actually very real for us as GPs, and that makes us think about how we treat the people that we see. So thanks a lot. Yeah, that's great.